So you're welcome to another edition of this series. Hopefully in the next few minutes, this is going to be a very short one. In the next few minutes, I'm going to be taking you on how to choose a study design. I want to start by saying that this is a topic that most people have problems with, and it's just because the way in which they got introduced to this topic in a lot of institutions. I think the way in which students or residents get introduced to this topic is a little not up to standard. I won't say substandard, but it's not up to the standard that is expected. And so most people have very serious difficulty in trying to find out what kind of study design they are using. And I think it's because most people don't know how important study design is. In a few years ago, one of my profs was supposed to attend a defense, and so that defense is not it's in another faculty. It's not even Faculty of Medicine, and so he had some issues that made him unavoidably absent. So he sent me to help him, to just represent him. I never knew anything about what was going to be presented. I'm not going to mention the faculty or the department, but I got there and there are very big people there, everybody there, the supervisors, the other people in all the other departments and the rest in the faculty. And it's a big show. There's food, there's everything. It's a final exam defense. And so the lady presented, she finished all her presentation, and then it was time for question and answers, and everybody seemed to be happy with what she had presented. It's not that I wasn't happy with what she has presented, but I didn't have a clue as per what she was doing. So I had a couple of questions to ask, a lot of questions, but the only question that really would make the difference with all the questions was, what study design did you use? What kind of study design is this? So I asked that question, and that was the end of the exam, because she didn't know the study design she used. Nobody could help her. The supervisors couldn't help her, and it was just funny. To cut the long story short, because the long story. Ever since then, they always invite me for their defense, and they send a lot of students to come so that I can explain to them, because I had to explain to them what this means. Okay, so the study design is something that is important. At the same time, it's something that is elusive, because most people, like I said, are not well, the way in which they are introduced to study designs is maybe, I'm thinking that's probably what's causing this whole gulf of misunderstanding with regards to study design. Okay, so I'm going to use this very quick synopsis. I have a couple of slides. A lot of them are repetitive. They are repetitive, so I don't think you'll have any issues trying to grasp. I'm repeating them so that I'm trying to enforce the idea so that you understand them a little more. Now, just a brief introduction. What is a study? Why are they saying study design? Why are we particular about the design of a study? What's even the study in the first place? Okay. And if we talk about the study, then it is just okay for us to, it's just like a segue into understanding what are the steps in a study. And I'm going to tell you this at a high level. So I'm giving you a high level view of what all of this mean. And once you get that high level view, like a bird's eye view, you can now cone down and understand what this whole thing is all about. Okay. Then why is this important? Right? And you see that the study design actually sits in the middle, right? It sits in the middle of very important steps. Okay. And I am going to attempt to classify study design. And I'm going to say this here is an attempt, because I have not seen a I'm sorry to say, I've not seen a complete classification of study design that doesn't have one small. And I think part of what is causing even the confusion for people is the fact that the classifications also sort of tend to mix some of these things up, so I'm not going to be presenting for you one classification that has 1 3 that you see, one is descriptive, one is not. I'm not going to do that, because I think that's probably the source of some of this confusion. Okay, and then how do you choose the best study design for your work? And I think that's the crux of this whole meeting today. How do you choose the best study design for your work? So I have a couple of questions. I call it the M.U.S.T rule. Okay, M.U.S.T. So it's the Abdulhakim's M.U.S.T rule. So I just made up this rule. So copyrights reserved, all rights reserved. But if you can answer those questions, 4 questions, M.U.S.T, right? You should not have any doubt in your mind as to what type of study design you are dealing with. So we're going to go through that M.U.S.T rule, and then I am going to give you a chance to ask questions after I've concluded, and then we can go to the end. Hopefully, we'll stay within the time frame. I had a small what's the name? I had a kind of small test that I wanted to give on the Kahoot, but I think we'll not have that luxury of time, so we're just going to skip that because of time, so that we can spend more time in this. And I'm not prepared to lecture here, please. So this is not a lecture. I just want you to know that this is information and advice, not a lecture. And with what I've given in the preamble as an introduction, this is a topic that most people tend to look at as complex. I don't see any complexity in it. So most people tend to look at it as complex. But even if it's complex, then the problem with having to try to explain something that is complex is it's a complex thing to explain something that is complex. The trying to explain it is a complex thing. And the only reason for me why I think it's complex, trying to explain something that looks complex, is the human brain. Okay, the human brain is one of the most powerful brains in the world, right? It's the top. That's why the top of the food chain. But unfortunately, as the brain is the most powerful, it's also one of the weakest, because with the human brain has to, especially an adult's brain. The child's brain sometimes is even stronger. An adult's brain, because of all the experiences he has had, the brain is always trying to predict what the next move is. Okay? And so the brain releases the amount of power that it has based on what the next move is. If the next move is complex, the brain, a lot of people, their brain is not strong enough to try to even attempt to do something that is complex. So the brain shuts down. So, and then the brain has so many things, there's the physical brain, there's the mind, there's the heart. Where's the brain? Where's the mind? Is it in the brain or is it in the heart? Thank God I'm speaking to medics now. So, is the mind within the heart? Is it in the soul? Is it in the brain? Okay, but that's by the way. So, but the human mind is also very complex. Okay, and the mind controls the brain, the physical brain. As if you don't believe that the mind and the brain are the same. So the human mind is like a cup. All right. So if you can see this cup, it's just like a glass cup. And this glass cup is very simple. It's just a glass cup. And if I want to put water in this cup, it's as simple as just getting a jug of water and pouring it into this cup. There's nothing as simple as that. Anybody can do it. In fact, even a kid can do that. So I pick up a mug and I can just pour water inside and drink and do whatever I want to do with this glass. All right. So with this glass, it's easy to pour water inside. But how would I be able to, how easy is it to pour water inside this cup if this cup was upside down? Upside down. No matter how much I try, I'm not going to be able to get one single cup of water inside, one single drop of water inside this cup. The same thing with the human mind. You see how simple this cup is? The human mind is just like that. The human mind, if it says it is not going to get this thing, it will never get it. That's the truth. If you put in your mind that you're not going to get it, it's board mass, it's further mass, it's algebra, it's something, you're not going to get it. Nothing in this world will be able to explain it for you to get it. You are just not going to get it. Just like having this cup upside down. Even if I'm by the beach where there are millions of gallons of water, I can't pour a single drop of water inside this cup as long as it's upside down. So I'm saying this here today for you to do me a favor. All I'm asking you to do is to turn your glass, look inside your mind, right? And turn that glass upside up and downside down, not upside down. Upside up and downside down. So that I pour a little information inside today. The information in which I wish to share across with each and every one of you tonight, it may seem rather extensive, but when you consider the capacity of the human brain and the amount of information that it can store and that it can decipher, then a few pages of information tonight, I don't think is going to overburden you. So I'm giving that as a disclaimer before we go into this. So all you need to just do is just to believe that you want to know this thing and then you're going to know it. There's nothing difficult in that. Now, it's important that you know this because this has to do with research. If you say you're a researcher and you don't know this, then there's trouble. So what do we mean when we say this study? Really study? Is it like going to study a book, carry a book and just study? Say I'm going, you see a medical student saying that I'm going to study. I'm going to class to study. Or what exactly do we mean by this study? So when we say study, it's basically just, we're just talking about a research, right? We're talking about you doing research, okay? So, and it's basically that process, that scientific process is a scientific process of trying to answer a question. Please listen to this definition very well. It's a plain old definition, but just if you get this first slide, this main slide, then every other thing would like piece together. So it's basically just a scientific process of trying to answer a question. But this time you're not just answering the question based on just what you think the answer is. No. You're trying to answer the question based on data that you've obtained from a population. And when I say population here, this population can be a population of animals. It can be a population of people. I don't know if you can mute any of these people joining because the sound is going to be distracting to so many other people. And then this is being recorded so that we don't, yeah. Okay. So when you hear study, they're saying research. So you hear some people saying research study design. It's just like and you see it in big journals like that, research study design, and you see, and that's like, for me, it's like a tautology, right? Because the study itself is a research. So you're either saying research design or a study design, but research study design is tautology for me. Okay, so this study is basically a scientific process of trying to answer a question. What do you want to do? You want to answer a question, but you don't want to answer this question just by guessing, or based on anecdotal evidence. No. You want to answer this question based on data that is obtained from a population. This population, in statistics or in research, when we say population, it can mean a population of hospitals. So it's either animate or inanimate objects. And that's statistics for you. When statistics talks about a population, they are talking about individuals or group of individuals or animals or hospitals or just animate or inanimate objects. What are we trying to do when we're doing a study or doing a research? Is basically just a detailed examination and analysis of a particular subject or a particular phenomenon or a particular event or a particular state. Okay, So if you are clear about this, you are required to do a study as part of the requirement for you being or for you to graduate your residency training program. So which is the same for most residency training programs all over the world. You have this requirement. So you are required to collect data, analyze that data, and use that data to answer a question. Now, this question is none other than your research question. If we're clear on this point, which is the most important point in this presentation, then every other thing is going to come in very simple. So this study, does it, before we even go into the whole concept about study design or no study design, are there steps? If you remember in our last meeting or last webinar, I said once you're an adult, you're an adult and you want to do anything, don't just jump into doing it. There are always steps. These steps are not just made up. Some people have sat down to actually go through the way people have done things for tens of thousands of years and have made it concise for you to really understand. So there are steps, and try to know those steps so that you know what you are doing. You're not just doing it because everybody's doing it. The college says write your research in this sequence. Do write chapter 1, chapter 2, chapter 1 is this, chapter 2, and you think they're just no, it's there's a reason why you're doing some of all of these things. The first step is for you to identify a problem, which hopefully most of you people did. You identified a problem. I'm seeing someone is saying you cannot see the shared screen. Khadija, what's happening? I have a pop-up, I think it's a chat. Then somebody said you cannot.
We can see it. Probably the person should log out and log in again because we can see it.
All right, fine. Okay. So the first step is identifying a problem. And this is where the problem is. Most people don't identify a problem. Most people just see something that is in fact, most people, I'm sorry to say, most people make up a problem and then you want to try to find answers to that problem that you made up by yourself, for God's sake. So the first step is identifying a problem. It's a problem that, and we're all clinicians here, or medics, let me put it that way. And there are a lot of problems in the world, a lot of problems in the medical world. So the first step is identifying a problem. But it's not just identifying the problem, because the problem is multifaceted, right? It has different facets. It has different factors that are leading to that problem. So the next thing that you want to do is to, you've identified the problem, then for you to now do a study, you're going to want to develop a question. There's a research question. That's the question that is going to guide your research study. Okay. And that's very, very, very important. So if you're saying you're doing research and you don't have a question that you are looking for answers, you are going to search for answers, then you are doing it the wrong way. Let me put it that way. Okay. The next thing is then you develop a design, a design, or you identify a design that is going to help you to answer that problem. Very important. The design helps you to answer that question. The answer to that question should be able to also help you to solve the problem. Please look at it this way. This is how it goes. Okay. There might be more steps than this, but this is a high level view of, just getting it summarized. There's a problem. You've identified that problem. The problem is multifaceted. You have some questions that you want to, with the answers to those questions, you can start attempting to solve the problem, But for you to be able to answer that question, you have to put in a design, okay? And this design is just a framework or is a set of methods and procedures that are used to collect data and analyze data to just be able to give you answers to that question. After you've done this, you're going to go and collect data. Remember, I said this study has to do with you collecting data to answer a question. You know, for you to do a study, the study is just, you know, is a research that you do to answer a question, and you have to do this by collecting data. You're not, you have the evidence is data from a population. Okay, so the next step is to collect data, and then finally you analyze as well as interpret. The interpretation of this the analysis that you've done would piggyback or circle back to help you to answer your question, and then you're on your way to solving the problem. Okay, so the whole thing about the research study design, which is this one that we're seeing here, right? It is just setup that helps you to decide on how you collect the data. Okay, where's my pen? Just 1 second. So this design, this study design, 1 second. Okay, so this study design itself, it helps you to decide on a lot of things: how you collect the data, right? How you do your analysis, all right? How to interpret the results, because there are different ways in which you can interpret the results, and you cannot interpret the results out of context. It has to be based on the context of what you are doing. Okay, the context of what you did or what you are doing. All right. So if you understand this flow, a question, the problem to the question to the design, right? And then you used what you've gotten that design to collect the appropriate data, analyze that data, and then interpret your results. And then you can now go back to solving as with the answers to this question, and that helps you in thinking of how you solve the problem. In a lot of instances, solving the problem is not part of the research. It's the beginning, but it's not part of the research. You may need even another research to be able to tell you how to solve that, the best way to solve that problem. Or the results of your research may be used by policymakers or may be used by other clinicians to help us solve this problem. And that's what most of us write in our justification, right? The information that you get, the answers to this your research question, you know, would be what would likely serve as information that people will use to solve these problems: policymakers, clinicians, other medics, and the rest like that. So that's by the way. Okay. Now, how important is this study design? If you just have seen that small schema that I put up in the last slide on those steps, you will know that that design helps you, is very important. And then it helps you it serves as a guide. It's a very strong guide that tells you that would govern everything you do from the moment in which that study design has been established. Okay, so as an example, the study design that you have chosen to use will determine what type of sampling you will do. What sampling technique are you going to use? Are you going to use a probability sampling technique or a non-probability sampling technique? Because for example, if what you are doing is a focus group discussion, you can't be talking of using a probability sampling technique, you know? So if part of the way in which you're going to collect your data is using interviews, an in-depth interview or a key informant interview or a focus group discussion, you can't be talking about a probability sampling technique. Okay, so your study design would govern the kind of sampling that you would use. Because if your study design is a qualitative study design, then you can't be thinking of using probability sampling techniques. I'll explain a little more. If your study design is a quantitative design, type of design, then you start thinking of probability sampling techniques. And even the probability sampling techniques, which particular one will you use will depend on the particular study design that you have. Similarly, and this is what most people don't want to hear, the study design will, if you have had any problems with calculating your sample size, it's just because you did not understand that the sample size calculation 100% relies on the study design, right? So I've received more than 1 million calls or thousands of calls. People who call me and say, please, they've gone to present, they scattered them in the presentation, they didn't know their sample size, they have to come back again to represent. Even the people there in the presentation could not help him or her out. They just said, go and look for somebody to help you out. Study design, study did, I couldn't calculate my sample size. And the first question I'll ask you, because I'll solve your problem on the phone, on that same call within 1 minute or 2 minutes. All right, God willing. What is your study design? Because they're like, the last time I checked, there are like 20 different formulas for calculating sample size. Most of you just know one formula. And that one formula that most people know is only for cross-sectional studies. And even not just any kind of cross-sectional study. It's a cross-sectional study that the primary outcome variable is a quantitative variable. But you can have a cross-sectional study that the primary outcome variable is a qualitative variable. So which formula would you use? So the study design is very important. The moment you are just thinking of your study design, don't just be thinking about just this study design. It's clinical trial. Is this? It would, the kind of analysis that you want to do would also depend on the study design. So the next thing is analysis, right? And then finally, even if you've gotten the hang of your sampling, you've gotten the sample size determination, you know the analysis, the way in which you interpret the results is very, very important. So just to pause here to do a kind of pulse check. You know that if you are doing a cross-sectional study, there's some kind of analysis that you can do. You can be talking of prevalence. If you are doing a case control study, for example, you can't be saying you are doing risk ratio analysis. You can't be calculating risk ratio, relative risk. Why are you calculating relative risk? Relative risk has to do with incidence. How can you get incidence in a case control study? You can't get incidence. You can get a prevalence, and you have fixed the prevalence because you are picking cases. Already you have fixed the prevalence in that study. You are going to pick 500 cases. So you can't come and be doing a cross-sectional study and be saying you are using a McNemar's chi-square test, for example. A McNemar's chi-square test is for paired samples. You can't get paired samples when you are doing a cross-sectional study. A cross-sectional study is one shot. It's a snapshot. Outcome and exposure and outcome, you are getting it at the same time, just like having a picture. So you can't be talking about doing one kind of analysis or the other. The kind of analysis that you will do will depend on the study design that you have. Then even the interpretation. I was reviewing an article for one journal, and the conclusion just took me off. You did a cross-sectional study, and you are saying that now from the analysis, you did very robust analysis, no doubt about that. But you are saying now from the analysis that you've done, you can now clearly say that is this exposure that led to this outcome. How? In a cross-sectional study? Don't even dream of saying that. That paper was rejected very quickly from an international journal. You don't even know what you are saying. It's like you are just off. A cross-sectional study cannot tell you that. A cross-sectional study is not even used for causality or causation. You can't be talking about causation, and you can be talking about association. And that's just because you're only generating a hypothesis that you have to go further to test before you say that. All right. That's by the way. Okay. I'm just trying to say here with these 4 points, and there are so many other points that we can bring out, and to tell you how important this study design is. In the college, usually it's just one word, it's one line. You say, for this study, if you're writing a proposal, I'll be using a cross-sectional study design. One line. But that one line is a commitment, very big commitment. that you need to understand the implications of that one line that you have written. Very important for sampling, very important for sample size determination, very important for analysis, and super, super important for the kind of interpretations that you can get. That is the context of your work. Okay, so I hope this will generate a lot of questions at the end. So how do you classify study designs? Now, I'm going to go into one realm. So I'm giving a disclaimer before I go into that realm. This is a realm that most people don't like going into. Okay, because first of all, I think for most of you clinicians, aside from the public health people or on this call, for most clinicians, from what at least from the small knowledge I have seen other dissertations from so many other from all the colleges, at least I know, and from the different departments and faculties. I know that what is required in most of the times when they talk about study designs, most people are limited to, there are limitations because the college is also looking at the fact that you have just a limited amount of time to be able to do that dissertation, and so it's not every kind of study design that you can use. And when we get there, you'll see what I'm talking about. So, but a lot of people leave off this aspect, which is the qualitative aspect. So we're not going to go into this because I know for most people, as a clinician, you're not likely going to be doing this, except if you're in public health. You're not going to be doing anything qualitative. You're going to be doing mostly quantitative. And I'm sure people will pick me up on this. But yeah, when it comes to discussion, we can discuss a little more. Okay, so I want to start by going more high level, because most people, when they talk about study designs, they just what is their focus is just quantitative study design. But the world is bigger than what you are thinking. All right, so it can either be from the highest level now, bird's eye view, 500,000 feet up above sea level. When you're talking about study designs, it can either be qualitative or quantitative. Most people have not heard this, I'm sorry to say. Okay, qualitative and quantitative. All right, now when it's qualitative, there are about 6 or a little more. I'm just going to quickly talk about the common ones very quickly, like 1 minute, because that's not what we're here for. I know most people on this call, or maybe the people that might be watching the video when it's put online, or most people on this call are probably not prepared and or probably not going to be doing any kind of qualitative research. And it's very important that you understand the difference between qualitative research and quantitative research. They are two different things entirely. But I think for most parts of the college, the kind of research that is expected from most of you is quantitative, not qualitative. Now, remember that you can do a research that combines both qualitative methods and quantitative methods together. And that's what is called a mixed method study. Okay, but that's by the way. All right. So the first one is something that is called like a phenomenon, right? Phenomenology. Okay. And then there's the grounded theory. There's ethnography. There's what we call the historical study, is a kind of design. And then we have the active research studies. Now, the active research studies here, they're not very common around here. Okay, they're not very common, even among the people doing philosophy and all the rest. They're not still very common around in Nigeria. Okay, and then we have the one that is most common, that's the case studies. Okay, like I said, I'm not going to go too much into the details into this. Just to give you this, who is off, someone's off mute and is causing a lot of trouble. Okay, so just to give you a very broad idea about this. So when you talk about this first one, which is talking about like a phenomenon, right? In maybe before I even come here, let me just go back a little. Let me go one step back. Quantitative, qualitative. Anybody knows the difference? Because I don't want, this is becoming like a lecture and I'm not prepared to even do any lecture here. So anybody, can you come off mute to just tell us if you know the difference between quantitative and qualitative research? Trying to go back one step.
Good
Yes.
evening, sir.
Yes, please.
Thank you very much for the lecture. My simple understanding of the difference is that qualitative research finds the reason, the why behind the numbers.
Very good. Very good. Okay. I think in short, that's 100%. That's 100% without mincing much words. So you are going into for the qualitative research, you are actually going into it's not superficial. You're going to, everybody knows quantitative research. You're going to do something that you can count and be giving us percentage. Say there are 50 men, 20 women, the male-female ratio is 20%. You know, you're going to do something that you want to count and you're going to be dealing with. Even if what you are dealing with is not just numbers, because a lot of people get this confused. They think quantitative research is dealing with quantitative variables, while qualitative research is dealing with qualitative variables. That's not correct, right? Because even in quantitative research, you might be dealing with qualitative variables. You might be asking for gender, for example, and you are just only getting male, female. By the end of the day, remember, you're going to say this so percent is male, this so percent is female. How many males do we have? How many females do we have? You know, and you use that for your interpretation. But in qualitative research, please get this difference very clearly, because for some reason, some people still don't get this. The kind of data that you're collecting in a lot of instances is pages, plenty pages. Imagine that you went to collect data and what you have is a video recording or an audio recording, 1 hour audio recording. It's not a structured kind of thing that you have questionnaire and you are saying, do you know, yes or no? No. Here is a clear, it's you have pages of information. You have note takers. You have someone that will be taking note and just writing stories. Like you'll be hearing a lot of, because you want to find out the reason. You are going in depth. You're going why, not just the what, but why. What is happening here? Okay, and those ones also have their design. It's not the same kind of design that we use. So for the phenomenology here, what they do here is the design here is to examine someone's experience. So you hear them calling this lived experiences. People go to, in fact, the aim here is to describe the meaning of the experience that someone has with regards to a particular phenomenon, you know. So there's a lady that studied the experiences that mothers go through when they have a child that is living with HIV. So what in this kind of design, you know, in a lot of instances, you want to get the person can tell you a story of, he can tell you a 10-year-old story of how he has been living with this child, how the child got HIV, all this. Those are you are getting the experience. So you are examining human experience through the description that is provided by the persons that are involved. Okay. The next one is, and I'll give you an example, is something that's grounded theory. The aim here is to develop a theory, right? And this theory is going to be grounded on the data that you collected. And this data is qualitative data. So it's a qualitative study design. The idea here is to generate theories, right? So like, for example, in 2005, we had 2 philosophers that developed a theory. This theory is called the theory of optimizing personal control to facilitate emotional comfort, right? So what they did is they interviewed 40 patients for a long period of time. They didn't have questionnaires asking age. No. They interviewed 40 patients and I think for each patient, they spent 75 hours just trying to get, that. So you can understand the pages and pages and pages of narrations. It's just narrations, interviews, discussions with the patients, and back and forth. Okay. And they found out and they developed that theory on, how patients can influence their environment. And if the patients themselves are able to influence their environment, they can in turn lead to their own emotional comfort. And then this has helped, and this particular theory has helped a lot of psychiatrists, psychologists, and the rest that are just based on that small research that they did among just 40 patients, and they spent 75 hours each per patient. That's grounded theory. The aim is to collect data, analyze it, qualitative data, analyze it, and develop a grounded theory about that data that has been collected. Okay. Then we have ethnography, and as the name implies, this just has to do with you collecting qualitative data. So it's a qualitative study design also here. But here you are learning from people, okay, and it's different from the phenomenology that we talked about earlier, because here what you are learning, everything about this is about cultural groups, about ethnicities, their culture. So in fact, in some cases, we had a woman that she's an ethnographer. I think she lived in one of these villages in southern Kaduna for maybe like 40 years, just studying their ethnicity, studying their ethnicity. I think she's a missioner, but she lived there and she's doing ethnographic studies. So she, in this kind of study, the researcher will live with the people and become even part of their culture just to be able to study that kind of culture. That's called ethnography. And then you have the historical one. Here, the kind of design is looking into relics, artifacts. We don't do this very much in medicine, but even we have a lot of historical medical studies that have looked into old sources, to find out how we can relate what has happened in the past to what we are seeing now. We're seeing corona, we're seeing monkeypox, we're seeing Ebola, we're seeing the new strains of Ebola, we're seeing, so what has happened in the past, how can we relate it to the future? All right. Like I said, a lot of these things are not allowed in the college. I'm just giving you just a very quick sneak peek so you know that there are also qualitative study designs. Action research, I don't think I've seen anyone that's been done in Nigeria. I'm not very versed with looking at literature very much, but as the name implies here, is a kind of qualitative research design where the aim actually here is to improve the practice of something, right? And at the same time, studying the effects of that improvement that you have done. So imagine that you want to implement a system in the hospital, in our clinics, that ensures that anybody that comes into the hospital doesn't need to pay. They just quickly treat the person, and then maybe afterwards the person makes his payment based on a kind of agreement that you have over time, and then we want to see how this works. People who conduct a qualitative kind of study where we are interviewing patients, we're interviewing the hospital staff, and at the same time we're already implementing it and conducting that study. So the implementation of the solution that we're thinking of is part of the research. The idea about this is not to generalize, not that if we do it in AB we can generalize to all the other universities, no, it's particular for that setting, but here you are implementing a solution that you have thought of. You've seen a problem, you're implementing the solution to that problem, and as you're implementing that solution, you are also doing the research. The implementation is part of the research. Not very, very common, but it's a kind of qualitative stuff. And then lastly is case studies. What most people do when they say they did qualitative stuff is case studies. These are like in-depth examinations of people and groups of people, and this can be people in a particular institution or and the main aim of this is just to generate hypotheses, or sometimes to triangulate the results that you have with a quantitative study that you have done. So, and most people use this kind of design when they are doing mixed method study, where they have to have some qualitative and some quantitative research and put them together in a mixed method. So this is just in a very quick nutshell, a classification of study designs. I have full videos on this. If you check on my YouTube channel, I can't remember which of the channels I have it on, but maybe I'll send a link to Khadija if you want to look at this. So I did this very quickly so that we can go into quantitative research design or study designs. Okay, so most of the time when you hear quantitative study designs, I'm sorry to say they are stealing this from epidemiology, because the real studies, sorry to don't say I'm biased, if you like say I'm biased, but it's coming from epidemiology, and that's public health. And you cannot talk about epidemiology without statistics, biostatistics. So it's epidemiology and biostatistics, right? And that's the crux of any medical research that you are doing. It has its origins from epidemiological research, epidemiological study. Anyhow you want to paint it, if you like, be jealous about public health people, you're on your own. It's none of my business. You know, I'm not apologetic about that. But and that's why anytime it comes to study designs or all these things about statistics and the rest, they'll say go and look for a public health person. So we're not apologetic about that. I'm sorry to say. If you're feeling sad about that, sorry about that. Come on, when you finish your residency, come and do public health residency again. It's very easy. It's not something that is difficult at all. All right, sorry about that. Okay, so when you talk about this, they just stole everything from epidemiological study design. So I'm just going to be describing what we understand as epidemiological study designs, and these are mainly quantitative study designs. So what most of you have been hearing before about study designs and the rest of that is just here. I know a lot of people are not very familiar with the qualitative one, and that's why I just quickly ran through it. The college does not have any particular requirements, at least as far as I know, that you must do a qualitative study design. But I think that what they are particular about is quantitative study design, quantitative studies. And you see from all, if you have gone to your library in the National Hospital or any of your universities or wherever you're doing your residency, and you go and see, you see that all the studies you're going to see, the highest you'll see has mixed method, and that mixed method is just a case study that was used as part of the qualitative aspect. And even there, the person never mentioned it there is a case study. He just said mixed method, and he thinks, a lot of people, they think, even when they are doing mixed method studies, that they will say the study design. When they talk about study design, they will still just use the study design of quantitative study, and then the qualitative one, they never mention what the study design is. Now, also, I want to mention before I go ahead, so people don't pick me up on this, because this video is going to be all over the world. Some qualitative study designs can still be used to collect quantitative data. And the reason behind this is the study design is not the same thing as data collection. All right. So if we are talking about qualitative study designs, there are ways in which you can collect qualitative data. You know, focus group discussions, in-depth interviews, the key informant interviews. You know, so there are standard ways in which you can connect. But you know, people tend to mix and match, and so you're doing a key informant interview, but you want to use also some questionnaire to collect some information, or you have a structured guide that you use to collect some information, which you also want to use to like get out some small quantitative stuff to say, okay, I interviewed 30 people, and out of the 30 people, 20 are males, 10 are females, but it's a qualitative study that you want to do. Okay, so I think that's discussion for another day. Just know that even though there are qualitative study designs, there are also methods in which you collect the data, also qualitative methods. We're going into study designs for epidemiological study designs, and the first one is called a case report. This is the lowest level. I tried to arrange this in a sequence. By no means is this a complete sequence, and I'm only going to talk about the ones that are very common, not necessarily the ones that are accepted in the college. And maybe we'll now be able to piece them out and see from your experience also, and see which ones have you seen being done in the college, which ones are not accepted at all, which ones are discouraged. Okay, The first one is case report. And this case report is the lowest level, right? Is the lowest level. What is done here is what we call the first line of evidence. Okay, so you have a single patient. Sorry, I wrote something down. I can't find it, but I want us to go through this. Okay, so for each study that we mention, we're going to talk about four things. Okay, so now I have finished. Let me even say that I have finished this presentation, and now we want to go to discussion. Okay, so I'm going to be asking some questions, and I'm going to be trying to explain four things. So either I'm asking the questions or I'm not asking, but I'm trying to explain four things. The first thing is what I call manipulation. Manipulation. Okay. Manipulation, I'm not talking about this kind of scam, Nigerian kind of say manipulate, you're going to manipulate people. No. When we talk about manipulation in research, we're talking about whether there's going to be an intervention or not, whether you are trying to change the outcome by trying to like maybe give a drug or give a vaccine or withdraw something, or so that's manipulation. So in each of these study designs that we're going to be talking about, I'm going to mention, I'm not going to be able to describe this. 2 hours is not enough for us for me to describe, to explain. This is a whole course in university for me to explain all the study designs and the rest like that. But I'm going to, for each of the study design, just to make sure that you get the direction. And even if you're thinking of your own design now, you have an idea. Even by the time I finish going through these 10 designs, different designs, epidemiological study designs, you have an idea already what your own study design is. So the first thing we'll be talking about is manipulation. Please, if you have to write it down somewhere. Manipulation, because I'm going to ask whether there was manipulation, whether this particular design allows you to manipulate or just observe. What is the researcher doing? Is he manipulating something or just observing? All he's going to go and do is just to go and look and come back. Look, take some recordings and come back. Okay, so we have manipulation. All right. The next one is unit of study. Is this researcher studying, or is this design allowing you to study individuals or allowing you to study a population as a whole, as a group population, or individuals? Okay, that's number 2. I'm going to explain that a little further so you don't get confused. Then the next one is how many samples are you dealing with? One sample as a whole or multiple samples? I'm talking of a group, one group, another group, a third group. Are you dealing with one group or multiple groups? Okay. And then the last one is the timeline. What is the timeline? And when we talk about timeline, any public health physician, the first thing that comes to his head is exposure and outcome. Everybody knows that the natural history of a disease, you have an exposure, right? First of all, and then that exposure leads to the disease, exposure and outcome. So the natural history, the normal timeline is from exposure to outcome. So manipulation, unit of study, I'm going to be using these 4 to explain all of them, all the 10, these 4 points. And once you get this, nobody can take it away from you again. Like I said, it sounds complex, but once you understand these 4 things, then you are able to, any situation in this world, you'll be able to say what kind of study design we're talking about. Manipulation, unit of study, number of samples, or we say samples, or groups, if you want to put it that way, and then timeline. Okay, so we'll start with this first one. Let me quickly just describe what this case report is. The case report is just you having an atypical situation, an atypical presentation of a particular disease or ailment. It might even be a disease that you have never heard of before. It's just coming up. You know, one single individual comes up with an atypical presentation, and we study that one single individual. We collect blood, we do this, check the height, check the weight, do whatever we want to do on that single individual, and we write up our report. That's the complete study. Manipulation, no. We're not manipulating anything. We're just reporting what we have observed. We're not trying to change anything. We're not trying to change the outcome in that study. Okay? Who can remember what the second point is? Who can remember what the second one that we're looking at?
Exposure. Timeline.
Unit
of study. Okay. So is this unit of study individuals or a population as a whole? Can anybody answer that?
Individual.
Individual, right? So because we're going to be collecting is individual. Okay, very good. The next one is what? Can you remind me? The next one, I can't remember. If you can remind me, what's the next one? Sample, very good. So this is it one sample or more than one sample? What I mean here, group. We have like multiple groups. So this is just one person. It's even just one individual. So know anything about that. And then the timeline. At that point in time, when we're seeing this individual, has the exposure occurred first? At that point in time, when we're seeing this individual, has the outcome occurred?
Yes.
So exposure and outcome have already occurred. This person had been exposed maybe 5 years ago. Now he's just coming down with one atypical type of. And I'll give you an example of something that happened in our own facility. I'm sure the very good doctor that wrote that case report, I think it's published now in a very big international journal. I'm sure she'll probably watch this video and she can remember and she'll probably laugh. Okay, so it was presented in a conference, but it happened in our own facility. So we had this lady. It's a young girl. I'm not going to mention any tribe or anything, but it's a young girl that came to the hospital. She came to, and the lady that examined her was the one that wrote this case report, also with some other authors. But just to quickly cut the long story short, she saw this woman. I think she was a senior registrar then. She was a senior registrar on call then. And she saw this young lady. I think the lady is just like 17, 18 years old. And this lady had a mass, a cervical mass. Every single thing, if we have people on O&G on the call here, they'll probably know what I'm talking about. Every single thing about cervical CA, every single clinical sign, clinical as well as even diagnostic signs for cervical CA, they haven't gone to pathology, but every single thing, even they did ultrasound and everything, they checked all, did all the necessary stuff. Everything pointed to cervical CA. The only thing that was wrong was the fact that her age does not even tally. Cervical CA is not something you find in that kind of age group. Very atypical presentation. This lady went home thinking that something is just not correct here. Something is not right. When she came back for call, came back in the night for call, she said she, looked at the case notes again, said, let her do some examinations. And usually, there's bleeding, vaginal bleeding, all this kind of stuff. And, usually you don't poke anything into that place because you can trigger some kind of bleeding that, man, it's theater or else there's trouble. But she decided to tactically just, because the mass was there, you look at that big mass and everything, used a forceps, tried to, gently, just not to provoke any further bleeding or anything. And when she pulled out, she felt something hard, what can that be? Just take the chance. I think I might have to delete this portion from this video because I might put it on YouTube. So she put the thing inside and she felt something hard, and using that sponge holding forceps, I don't know whether it's sponge holding forceps, so don't quote me anywhere. And she pulled, and she just took the chance. If anything is going to happen to her, let's see. She pulled it out, and do you know what came out? I won't even allow any of you to guess. But what she saw was a jaw, a small jaw. This is the jaw of a lamb, a baby goat. She pulled it out from there, I'm telling you. And I used to have the picture of all those things. She started, it was scary, something like diabolic or something crazy, She pulled it out and then she dropped it on the table. It's serious. Continued to poke. Pulled out a nail, stick, one thing that is tied with thread. Started pulling out. If you see the things that were pulled out from that place, oh my God. 24 hours, 48 hours after, when they checked this lady, everything, all the swelling, everything has subsided. She didn't have any uterine cervical CAO. What she had was those things that were causing that. And now to worsen the situation was that when they asked her that, how did these things get into that place? She said she doesn't know. So you guys are on this call now. Can you guess how those things got there? She doesn't know. And sincerely, she wasn't lying. She doesn't know how those things got there. And the whole thing was resolved. It was inflammation that was causing that mass and all those things, that these things have been there for months. She wrote that very beautiful report, and it's published. It was presented in a very beautiful conference. That's the case report. So can you guess what, if you know about this story, please don't come off mute. Don't come off mute. But if you have an idea of what you think is happening here, because the girl doesn't know how it got there, but it's there. Who knows?
Could it be a teratoma?
Teratoma, with nail and stick. Which kind of teratoma is that one now? Hajarabi. Which kind of teratoma? That's the Nigerian teratoma.
I think it could possibly be an insertion unknown to her for a purpose, maybe local.
Very good, very good, very good. So this lady had secondary infertility. Secondary infertility, and this is why even the data that you collect for something as simple as a case report is very important. She had secondary infertility. She has been looking for a second. She had delivered before. She had been looking for another child. The husband carried her and went to dump her with one babalao. One of all these people is babalao, I call him. And the guy had been drugging the lady and inserting so much rubbish into her. Very, very crazy stuff. That's the case report. One single individual, one single report, but detailed information about that person. Okay? I hope this is clear. No manipulation. Good. No manipulation. Is a single person. Exposure and outcome already has occurred at the same time. The timeline is very straight. We understand the timeline. The next one is case series. If we have this kind of situation now, somebody will have asked me that what happened? What did we now do for the babalao? We didn't do anything for him. It's not our own business to go and be chasing babalao people around. We just told them because the girl was saying was that for the number of weeks that she has stayed with the person doing all this rubbish, once she eats, she just knows that she just sleeps. The guy was putting Valium and some things inside her drink or whatever, and she was sleeping, and they were trying all sorts of rubbish. If, for instance, now, seeing that situation, it has been reported, right? 2 weeks after, we now see another case again like that, the same story. Then maybe 1 month after, we now see, when we have a collection of atypical cases like that, what we have is called a case series. So this one reports data about individuals in a group, right, that have atypical features. It's like recently we had a person that had COVID, he had monkeypox, and he also had HIV. You know, mainly monkeypox, HIV, they go very close hand in hand because of the kind of it has some behavioral risk factors also. Okay, so and now we had 1 or 2, 3, 4, 5 cases too of similar nature. When you write a report, you do a study on those individuals, individual level, but you are bringing them together, right? What you have is called a case series. Okay, manipulation, 0. You are just observing and reporting what you have done. You are not like trying to manipulate, trying to change the outcome. You are going to treat. It's not treat. We're talking as part of the research. You're not trying to do any kind of manipulation. There's no manipulation. The unit of study is individuals, right? The unit of study is individuals. Our what's the other one? Sample. What do we call the third one? Can anybody remind me?
Number of sample.
Number of samples is just one. It's just one because it's just individual. We're not taking groups of samples, and you see when this number of samples will change, right? That's when we talk about analytical studies, because now we're just talking about descriptive studies. I'm going to go a little further. Don't worry. I just want you to get into the groove. That's why I said it's going to be repetitive. I want you to get into the groove. Okay. So the next one is the timeline, right? Exposure outcome. Has the exposure occurred? Anybody? Exposure occurred?
Yes.
Outcome
Yes.
occurred? Outcome occurred?
Yes.
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 Very good. Very good. Very good.
Yes,
Okay,
yes.
so that's a case series. It's data from a group that has these atypical features that identify the medical problem. And this is very, very important because case reports and case series were very, very important they have been important throughout the history of medicine. HIV was as a result of a case report or case series in a men that had, if you remember that whole story. All right. So, and in a lot of times, as clinicians, we know particular symptoms and signs that people come up with when they have a particular disease. And if you have a very strong, to be a good clinician, you have to have a very strong index of suspicion. You have to have a very strong acumen to look at all those signs and symptoms and tell it and say, this is what the person has, right? Not just see fever and say malaria. We know that. Everybody knows that one, right? So in a lot of instances, these case reports and case series have helped us to know some of these atypical presentations of some of these diseases. You are seeing somebody presenting with COVID, for example, and there's absolutely no cough, there's nothing. The only thing that would, in fact, you cannot even suspect there's COVID. The only time they knew it was COVID that this person had was when they checked when they did an X-ray and they found the whole ground glass appear. Everything was just, I had a situation in the early times of COVID and nobody knew very much about COVID. Everybody was thinking there's cough, there's this, there's that. I had this very close friend in the UK, and they were going to see people. They're seeing people. Part of their job, they see people, GPs. They see people at home, and So there's this elderly woman that was always calling in. She says she's not feeling well. She wants the doctor to come and see her, and the rest of that. She had a young daughter too that would just do the one that would call. This woman had, I think what even happened. She was just sad. It was more of like some psychological trauma. Said because of the lockdown, the coffee shop that is in front of our house where she used to just go and chill, and the elderly woman where she used to go and chill, that they closed the place up. So she's just sad. She doesn't even know what to do with her life. She's so sad. She said they should call her personal doctor again. They come. So this time they called this doctor for the fact, I think she was trying to come down the staircase and then she missed a step and then she fell down and then she had maybe a fracture or something. She had a dislocation or something. This time the doctor said she has to come in. So she came in and they did some, they did X-ray and the rest. And that was when they found out this one had COVID all the while. you know, by the features on the X-ray, everything was just atypical of what people naturally knew about COVID. And in such cases like that, people started knowing that this thing can present like this, and it can present like this, and it can present. Someone is off. Someone is. Khadija, can you mute this person or? Okay. I think we'll soon start doing those kind of meetings that everybody's going to be on mute by force till time for question and answers. There's one setting that you can do that. Maybe I'll leave the NHA guys to find out. Okay, so that's that.
We apologize for the
No, it's okay. It's okay. It's okay. So that's that for case series. The next one is called ecological study. Now, the difference here with all of them is the fact that in an ecological study, what happens in an ecological study is we're not looking at individuals. We're not particular about individuals. We're particular about an entire group. We're particular about the population. What we're trying to do is to explore some kind of statistical relationship between outcome and exposure, right, in a group. So it's not an individual level thing. Our analysis is not individual level. Let me give an example. If I give an example, most people will get this one time. In an ecological study, and this is not something that is acceptable in the college, as far as I know. In an ecological study, there's a study that was done to see whether there was an association between salt consumption and hypertension in a particular community, okay, in Kaduna, for example. So what they did was they collected data, salt consumption data. They can't get each individual to get their salt consumption data. So what they did was they got the manager of Dangote that supplies salt to Kaduna and say how much salt was supplied to this community in this so year, 2017, 18, 19, 20, like that. And then we went to our records, health records, and then we found out our prevalence of hypertension in those years, those same years. And then we plot a graph. We plot a chart. I don't want to draw on this. We plot a chart like this. And then we put hypertension here. And then we put salt consumption here. You know? And we plotted for the different years and we got something like this. You know, it's easy to say that salt consumption, increasing salt consumption causes hypertension, right? Anybody on the call?
Yes, sir.
Yeah, because we're associating now, we're doing, and that's why this study is called a correlation study. It's the same thing as a correlational study, right? So what we're doing is we're just exploring statistical relationship between the outcome of interest and the exposure in a population as a whole. But I hope you know that this can be fundamentally wrong. There can be a very big disaster here waiting for us. Why? Because we're just assuming that everybody consumes salt. All those hypertensive patients that made our prevalence of hypertension, they consume salt. We're also assuming that every person, we're assuming that all the salt that they are selling there is for consumption. People use salt for other things. I'm sure we're all aware that salt can be used. Even people that die, they use salt for other things. So if we're just looking at, ideally we should look at, this guy is hypertensive. Did you consume salt or not? This other guy is not hypertensive. Did you consume salt or not? And then we do a statistical analysis to find out. But no, we're saying the whole of Kaduna State, this is their level of hypertension and this is their salt consumption. And we're trying to correlate them together. So this particular study is something that leads to a very big bias that we call ecological fallacy. And it's based on what I've just explained. It's a fallacy. It's wrong. That association is because it's at a population level. And now let's go back to algorithm that we're using, is there any form of manipulation on the patient or on the population? No. All right. What is our unit of study? Is the population. It's the population as a whole. Okay. What is our sample? How many samples are we taking? Is it one sample or multiple samples? We're just taking one sample from one population, one information from one population. Okay. And then when we look at the timeline, exposure, outcome, everything at one point in time. We're not looking at, we're looking at the relationship between exposure and outcome, but we can't even say whether exposure came before outcome or outcome comes before exposure, because we're just getting everything. For God's sake, even the hypertensive patients may have been hypertensive even long before that year that we're checking. They might be hypertensive 20, 30 years ago, but they're still going to add up to the prevalence at this point in time that we're looking at. And we're just looking at salt consumption now. So how come we're trying to still see if we can see if there's a correlation or not? So that leads to what we call this ecological fallacy. The next one is cross-sectional study, and everybody knows about this, right? It's just a snapshot, okay? So here, the exposure and outcome, we see it at the same time. And what we do in a cross-sectional study is something that just helps us to generate a hypothesis, because we cannot say the exposure was the one that led to the outcome. It's the story of the chicken and the egg. Which one came first? Is it the egg that first came to this world, then the chicken laid egg, then the egg laid, that's the same kind of situation. Exposure and outcome are gotten at the same time. For example, and this is also called a prevalence study. For example, we want to find out the prevalence of hypertension among everybody on this call, right? We're going to carry I don't know how many people are on this call, and all of you will go and check your blood pressures, and then when we check your blood pressure, we would say, okay, this person is hypertensive, this person is not hypertensive. So we get the prevalence. Now, because it might be difficult for us to get all of you physically to get your blood pressures, it might be very difficult to do that, and it might take us a long time. So I might see Khadija today, check her blood pressure, I say she's not hypertensive. See Jafar tomorrow, check his blood pressure, say he's not hypertensive. Then after like 2 weeks, I'll now see Rabi, check her blood, and as I'm going, it takes me 5 months to do that. Please listen very carefully, because this is where people start getting confused. It takes me 5 months to do that. This is where people will come and tell you that this is a prospective study. There's no such thing as that. This is still a cross-sectional study. The study took me 5 months. You can ask your questions later, but just I'm trying to bring in all those things that cause those confusion for people. As long as what you are taking there, the exposure and the outcome, you are getting that information at the same time from that individual that are collecting that data, then what you have is just a snapshot. It's just like if I say, everybody quickly check your blood pressure now, use your SFIG, maybe the electronic SFIG, quickly check your blood pressure and then put it in the chat. So someone says it's 170, another person says 148, and then at one snapshot, I can know who is hypertensive and who's not. And that's why it's called we just do a cross section of everybody that is on this call. Okay, this is a cross-sectional study. Manipulation, no, we're just observing those people. We're not doing any form of manipulation. There's no form of intervention. All right. The unit of study is individuals, okay, not a population. All right. The sample, the number of, even though we would get a group of people, we just take only one sample. It's a sample once. It's different from if I said I wanted to compare the level of hypertension, the prevalence of hypertension among people in national clinicians in national hospital and clinicians in ABU. I have to take a sample of the people in national hospital, and I must take a correct sample that represents the people of national hospital. That's one sample. And then I have to take a sample of the people in ABU, a good sample that represents those people. So I have 2 samples now. It's not the same thing as maybe some guys in ABU came to do some things in national hospital and they're all together in a small conference, and I say, okay, ABU, and then I just collect that population is the population of people attending a conference. It's not the population of national hospital and ABU. If I want to do a study to really compare, I cannot do that cross-sectional study and now say I'm now comparing ABU and this thing. There's no basis for comparison. So I'm taking a sample from ABU and taking a sample from National Hospital, and then I'm comparing. I have two samples then. But in this cross-sectional study, the classical cross-sectional study, you have one sample. Okay? Timeline, exposure, outcome at the same time. If, for instance, now I wanted to see whether there's a relationship between salt consumption and hypertension, for example, and I just checked people's blood pressure and then asked you how much of salt are you consuming. So I can see that now, most of the people that are consuming a lot of salt, you're consuming 20 grams of salt every day, and this is your blood pressure, you have hypertension. Then I'll say, is this salt that caused the hypertension? No way, you can't do that because you found out about the salt consumption and the hypertension at the same time. You don't know which one came first. Maybe this guy had hypertension since, I know of some people at medical school, when they just did their normal screening, entry medical school, they check them and say, this guy is hypertensive. And then when he got to school and he got used to cooking in the north and the rest of that, he puts a lot of salt in his food. And now when you're asking him 10 years after, he said he used to take plenty salt. And you check his blood pressure and he says he's hypertensive. And then you say, is the salt that caused hypertension? This guy has been hypertensive since he started chopping this salt now. You understand? So we're looking at the exposure and the outcome at the same time. You cannot say anything about causality when you are getting the exposure and outcome at the same time. Longitudinal study. Now, I want to break here to say that there's something that we call a comparative cross-sectional study, but that's not the classical cross-sectional study. That's a break off from cross-sectional study. So we're not going to talk about that now. If we get to question and answers, anybody has a question about that, we can talk a little more. But in a comparative cross-sectional study, is two groups that you have, two samples that you take, like I've just discussed, two samples that you take, not one sample. The standard cross-sectional study has just one sample. It's a sample of individuals on this call or clinicians in NHA or the rest like that. Okay. Longitudinal study. Okay. In a longitudinal study, here, what you're studying a group of people over time. So you're following them over time and collecting information over time. So this kind of study is called an incidence study, because from this, you can know whether someone has recently developed a disease or not. So imagine that we wanted to find out the incidence of hypertension among individuals in, let's use the National Hospital, okay? And then when we started the study, we're going to do this study over a period of 3 years, for example, and we want to see who are those new cases of hypertension in 3 years. So we get our people that we want to study, a group of people that want to study, and then all of them, we check their blood pressures. And when we check their blood pressures, we saw the people that were hypertensive. Those ones, we just put them out. They're not part of our study. Only the people that don't have hypertension. And then we continue to check over the 3 years. After maybe every week or every 2 weeks, we'll bring them and we'll check their blood pressure again. The same thing, we're checking the same thing over that period from the same individuals. So, if after 2 months, if initially when we checked, the people that we're using don't have any hypertension, after 2 months, we now see that 4 people are now hypertensive. You know that what we have now is the new cases of hypertension within that period. And then after like 10 months or another 1 year, we check, we're now seeing 30 people are hypertensive. And then so we can get the number of new cases of hypertension, and that's what is called incidence. Okay, as we're going, you are following people over time. All right. I don't want us to waste so much time, but at least you get the idea of now seeing whether there's manipulation, no manipulation, single individual, multiple individual address. So I don't waste so much time. Then there's the case control study. In a case control study, as the name implies, I have a video that's coming out very soon, how to calculate sample size for case control study using EpiInfo mobile. Hopefully, maybe this evening I'm going to launch it. So maybe you can check and then relate what I'm also saying here. In case control study, because there I explained what a case control study is in layman terms. In a case control study, you have cases of a disease and you have controls, people that don't have the disease. So you can see that you have two groups of people, two samples. You have one sample of people, these ones, they have the disease. The other sample of people, they don't have the disease, because we want to have a basis for comparison. And then we're going to look into their records, their health records, which is like looking into the past, and then seeing whether they had a particular exposure or not. This is the first time that we're having two groups. So I'm going to stop to explain this very well. Cases, controls. Two groups. Any manipulation? No, we're just observing these people, but we're just observing their records. Now, are we looking at these records? Are we looking at it prospectively or retrospectively? This is the point where retrospective study comes in. Please, most people mess the thing up because they go back and look at people's records. They say it's retrospective study that do. No. The retrospective study here that we're talking about is when you are trying to check from outcome. You have someone that has a disease, and from the outcome, you are looking back to see if the person had exposure. All right. So when you're talking about retrospective, no retrospective, it's not because of the way in which you collected the data, but it's the way in which you are looking at. Is it from the outcome to the exposure? Is that what you're looking for? Right? Are you looking at the exposure but if you're not looking at exposure information, you're not doing a retrospective study, even though you're looking into the records. If what you're looking for is disease, or you're looking for something that is not an exposure, then you shouldn't go around be saying I did retrospective study. Because classically, when you talk about retrospective study, any researcher, the first thing that comes to his head is a case control study. You have people that already have the disease, you are looking back to see exposure. Okay, so no manipulation is done. We're just observing. The unit of study is individuals. We're looking at individuals that have disease, individuals that don't have control. It's not population like ecological study. Okay, now what we're also looking at, if you look at this, I have a chat that's coming in. So someone's asking, then why do you have a control group in case control study? The control group is, and please you'll do yourself a very good favor if you can look at the video is not yet launched. I'm going to launch it soon. It's how to do the sample size calculation for case control study using EpiInfo. You can do it in like 1 second. But someone's asking a question in the chat. He says, then why are you using controls for a case control study? Now, in a case control study, you have cases, all right? Do you know that if we decided to just look at everybody that has lung cancer and then look back into their records, their history, and we see what percentage of them were smoking? If we saw that 80% of the people that had lung cancer are smokers, is it enough for you to say smoking is a risk factor for lung cancer? It's not enough. Do you know why it's not enough? That's a biased way, because there are some people that have lung cancer and have never smoked. So how did they get their own lung cancer? That's one. Then there are some people that have been smoking. They are very dangerous smokers. They will smoke 20, 30 packs a day. Until they die, they never got lung cancer. So how do you marry those things together? The only way you can marry this thing together is by doing, and it's to just start to give you an idea, is by doing what is called an analytical study. An analytical study uses more than one group of people. One group of people is the main study group. The other group is a comparison group, so that you can identify some of those differences. You need to have something to compare with. You need to have a basis for comparison. Why do you say, how come you can check someone's blood pressure and say the person is hypertensive? What are you looking at? You have a control, you have a measure, you have something that you are measuring it against, you have something that you are comparing it against. Okay, so if, for instance, we have two groups of people, now this is where the idea is. If you have two groups of people, and I like this question, if you have two groups of people, one group already has lung cancer, the other group doesn't have. If we look back into their histories, you know that among the people that have lung cancer, We will have smokers. Among the people that don't have lung cancer, you also have smokers. But now here's the trick. If the people that have lung cancer, the cigarette smoking, the level of exposure among the people that have lung cancer is significantly, that's the word. I don't want to use statistically, but it's significantly higher than the people that don't have lung cancer. Their exposure is significantly higher. Then we start to suspect. So you see, it's an analytical study. We start to suspect that this cigarette smoking is not a joke. Out of 10 people that had lung cancer, 9 of them are smoking. Then out of some other people that didn't have lung cancer, only 1 of them was smoking, or 2 people are smoking. Then you know that, yes. So if the amount of exposure in the diseased group, the cases, is way higher, significantly higher than in the controls, then we start to suspect that factor, that this is a risk factor. And then you can go ahead to do another study that will prove it, because this is just suspicion of causality. It's just suspicion. That's why you cannot do a case control study and come and beat your chest that, yes, it's cigarette smoking that. No. Until you have done other significant studies that will prove it. But this can give you an idea of what you are dealing with. Okay? I hope this answers your question. There'll still be chance for more questions. So let me just go to the next. So timeline. Can anybody tell me about timeline here? I know our time is already fast spent. Timeline. I want to leave at least 30 minutes for questions, and I think we're already almost at the top of the hour. Can anybody say anything about timeline here? Exposure, outcome. Are we getting them at the same time? Exposure, outcome. Anybody on the call? Okay, so I'll help you here. Exposure has already occurred. Outcome has occurred. But we're looking at the outcome, but we don't know what the exposure is. We're looking at the outcome. We have the outcome, and we're using that to check the level of exposure. So as a researcher, what you are looking for is the level of exposure. And you're going to look into the person's records past to see whether you can get that exposure. In a case control study, you'll be calculating something that is called odds ratio. And that's the factor that helps you to see whether that exposure is very likely to lead to that outcome. You can talk a little more about that later. The next one that you have is called a cohort study. Very different from a case control study. 2 groups also here. Here you have 2 groups of people, 2 samples that you're going to take, right? But you are starting in, this is where this is what is called a natural experiment. Natural experiment. You are not manipulating anything. You are just observing. But what you are doing here in a cohort study is remember, the natural history of disease is from exposure to outcome. That's the prospective nature of a disease. You get exposed, then after some time, for those diseases that have like cancers that have a long latency period, wait period, you'll be exposed now, maybe it's still 10 years before they discover, So you exposure, then outcome. So now we have a group of people that are exposed, but we need some control. We need to be able to, we don't want to just say, these people were exposed to cyanide. At the end of the day, they developed one cancer. No. These people were exposed, these people were not exposed. Then we follow them up, checking on them, seeing what disease did they develop at the end of the day, and then we compare. So if we wanted to see, whether cigarette smoking, for example, I keep on using this example, cigarette smoking causes lung cancer. We have a group of people, a cohort of people that are cigarette smokers, and then we have a control, very similar to these people. The only difference with this is that these ones don't smoke, they're not exposed. Then we start to study them for the next 20 years or 30 years. And then at the end of 30 years, we'll now come and say, these people that were smoking, let's see how many of them have developed lung cancer. And then these other people that were not smoking, how many of them? Because some people will not smoke, they'll still develop lung cancer. But now the difference here is, if the level of lung cancer among the people that were exposed is way significantly higher than the people, 9 out of 10 people that were smoking developed lung cancer. Whereas only 1 person out of the people that are not smoking, or 2 people, develop lung cancer. Then this cigarette smoking is also a source. But this one is a more, because at the time in which we started the study, it's only exposure that we know. We don't know the outcome. None of them have lung cancer. So we're going prospectively. It's a prospective study. When you're going from outcome, you have the disease people and you're looking back to see their exposure, then you are doing a retrospective study, and that's a case control study. I hope this is clear. No manipulation. 2 groups of people, individuals that you are studying individuals, not a population. It's individuals. We're collecting data from individuals, not a population level like ecological study. And then in the timeline, exposure is coming before outcome, and we're going from exposure to outcome. Okay, we have what is called a community trials. From this point on, we are manipulating. Okay, we're doing some form of manipulation. So imagine that we wanted to see whether if we wanted to see whether, let me give an example, maybe using what's that thing that they used to use to fortify bread? Who knows? Bread. Who knows what they use? Vitamin what?
A.
A. Okay, vitamin A. They put vitamin A. They can put any other thing to fortify. So imagine that we had a community, and this community, they are giving them fortified. They take fortified bread. This is not ethical. I'm just saying, but we have 2 communities. One community has supply of ethical. We are providing maybe providing bread that is fortified to this community, and the other community, they are not taking any fortified bread, for example. And then we now see the level of which what's the link to vitamin A, which xerophthalmia, or which disease is linked to vitamin A deficiency?
Xerophthalmia.
Very good. So at the end of maybe 5 months of giving these guys fortified bread, and the other guys were leaving them, it might not, I'm not talking of ethics here, because this might be ethically wrong, but I'm just giving you an idea. We are trying to change the outcome in this group because we're giving them a drug, or we're giving them vaccine, or we're trying to remove something from. That's what is called manipulation. That's an experimental study. In an experimental study, you manipulate. You try to change the outcome of events. In that study, as part of the study, you are trying to change something, and that's where we have these same clinical trials, which you have all those randomized control trials, drug trials, and the rest like that, right? Everybody knows that very well, at least we're clinicians here. And then there's what is called lab trials. I'm not going to talk about systematic review and meta-analysis, because those are not original research. Those are like secondary data analysis of original research. Here we're talking about original research. Systematic review, you collect different studies, mostly randomized control trials, and then you try to bring them together and get a final conclusion, one answer for all the studies. And meta-analysis is the data itself from that study that you're analyzing to give you one single figure that summarizes all that study. Okay, so this is that for study designs. I'm sorry I ran a little through it at the end, because I know most people are a little familiar with all these community trials, clinical trials, and lab trials. I want to give some time for us to ask questions, because I see we have only just like 20 minutes left. But I want to now give you something about this classification. So you see these groups here. If you notice, when I was saying these groups, there's no manipulation. So they are called observational studies. The researcher only goes to look at what is happening, takes his measurement or takes his recording, and goes away. That's all he does, right? He doesn't try to change the outcome of events, doesn't try to give them bread or give them drugs, or say one group is taking this drug, the other group is not taking this drug, or one group is taking this drug, the other group is taking placebo. He's not doing all of that. That's manipulation. I'm not saying manipulation in the bad sense. I'm saying that's what we call it, or intervention, right? Doing some kind of intervention. Okay. These other groups that are here are the groups that we call experimental studies. So you see some classifications where they say observational studies and experimental studies. Okay. Now, we have these groups also. These guys that are up here, we call them descriptive studies, because what you are doing, why is it called descriptive? Because what you are doing here is, in most times, you are just trying to describe what you observed, because you went to observe, right? You're just describing it, right? And what happens here is you have just individual level, one group of people, one sample. This is what we call a one sample study. One sample, not more than one sample, right? But if you look at this other group down here, these are the groups that we call analytic studies. They're analytic studies because they have more than one group. Case control, 2 groups. Cohort, 2 groups. Community trials, you can have 10 groups. Clinical trials, you can have 5, 6, 7 groups, 10 groups. Lab trials, you can have groups of people, you know, and each person is, each group has what you do for each of the groups. Okay, so how do you now choose a study design? So our discussion is just starting. All those other ones is preamble. You have your study, you are doing your study already, you have gone halfway, or you are writing your proposal. How do you choose your study design? This is what I call the Abdul-Hakim's M.U.S.T rule. So, and copyright, all rights reserved. Okay, so the first thing is, remember that the most important thing is your research question. If I see your research question, I should have an idea of your study design. If you have written your research question now, go back to your proposal. If your research question does not give anybody an idea of your study design, that's a fake research question. Because remember, the study design helps to answer the research question. Very important, very serious stuff. 4 questions you need to ask. And the answers to these 4 questions is what I'll ask you if you call me and say, Dr. Rokoba, they say I should call you, my supervisor, I should call you to ask you what my study design is. Is this same 4 questions I'll ask you? The first thing is, and it's funny, you're going to laugh. All right. Does this research contain any form of manipulation? Yes or no? So you see, if it contains manipulation, all the other first 7 that I listed, forget about it. It's not there. Those are observational studies. They're not experimental studies. So you can't be talking about case control, cohort. You can't be talking about those things. You're already going to manipulate. You're talking about one of these, either experimental, quasi-experimental, or any of all those experimental studies. Randomized or non-randomized. Okay? First question. If you say it does not contain manipulation, we're leaving out those 3. We're only left with 7 to contend with. So you see, our options are getting closer. Sharp, we'll get to your study design. Don't worry, don't even be afraid. We're going to get there now. The next thing is, what is your unit of study? If you say your unit of study is individual, or you are trying to look at a population as a group, if you say your unit of study is an individual, sharp, we're down to 6. We have dropped correlational studies, because correlational studies or ecological studies are the ones that deal with population as a whole. Okay, that's the U.M.U.S.T, right? Manipulation, unit of study. The next one is, does your research have 1 or more groups, 1 or more samples? Are you dealing with 2 groups? Chairman, just tell me now. Don't even stammer. Stop stammering. Are you dealing with 2 groups or 1 group? I need to know that answer now. If you say you're dealing with 2 groups, you see all the other ones up there: case report, case series, cross-sectional studies, query, we'll keep it there. Cross-sectional studies, part of it, we'll keep it there, query. But all the other ones are gone. We're left with case control, cohort, and to an extent, no longitudinal, no ecological, no case report, no case series. We're left with case control, cohort, and cross-sectional. Because we have a cross-sectional study that there's a cross-sectional study, specialized form of cross-sectional study, that is called a comparative cross-sectional study. That one has 2 groups. The final question that hits the nail on the head is, what is the timeline of your study? Are we seeing exposure and outcome at the same time? If that's what you are doing and you're having two groups, exposure outcome at the same time, don't waste your time. You are doing a comparative cross-sectional study. Nobody in the world is going to call it something else. Not your supervisor, nobody, not the reviewer, nobody, right? Exposure and outcome are occurred at the same time. You are just trying to find the prevalence in one group and prevalence in another group and compare. Comparative cross-sectional study quickly. All right. But if you are looking at diseased individuals, one group is diseased, the other group is not diseased, and you are looking at the exposure and trying to compare the exposure, chairman, you are doing a retrospective study. Call it anyhow you like. Let your supervisor call it anyhow, or your reviewer. You're doing a retrospective study, case control study. Please, just save yourself any trouble. But if what you're looking at is exposure and you're going to follow them up, which I know the college is not going to give you the chance to do that, to follow people up over time. The people in community medicine do what is called a quasi-experimental study. And in quasi-experimental study, I think that's the highest they're allowed to go, because you don't do any form of randomization, but you're allowed to follow people up for up to 6 months. I think some examiners even allow up to 1 year. But because you are doing residency, you are working, it's not going to be easy to be doing something, just following people up for up to 1. You should just do your work and collect your data and start to analyze, because you already have an idea of what you are doing. What is the timeline? Exposure to outcome. If the exposure has already occurred and you're wanting to see the outcome, then you are doing a cohort study. You're following up. If the diseases, you are looking at diseased individuals and non-diseased individuals, and you're trying to look at what exposure led to that disease, you have a case control study. Case closed. On the other end, if you had answered yes to the first question, do you have any form of manipulation? You say yes. Then there are some other questions that you can ask. Are you doing it in the community or in the field, which is field trials or community trials? Are you using a drug or you're not using a drug, and when you're using the drug, is it randomized? Are you randomizing the people or you're not randomizing the people? Randomized control trials or non-randomized trials? Are you using lab? Is it a kind of lab stuff? You're using lab trials, and all those other trials will come up there. Very, very simple, straight to the point. With these 4 must questions, you are good to go in determining whatever kind of study design that you use, as long as what you're talking about is epidemiological studies. Study designs are important. They serve as a guide. Remember that diagram I showed you. From the time in which you have your problem and then you give your research question, the study design helps you to get answer your research question. The study design tells you how you do your analysis, what kind of analysis you do, what kind of sampling you take, what kind of sampling technique you use, what kind of sampling determination you do, the sample size determination, the number of samples that you use, and then it also tells you the kind of analysis and the kind of way in which you're going to interpret your results. Okay? So, like I said, it depends on the research question. There are several ways in which your study designs can be classified. You have seen all those ways, all right? And if you are able to answer 4 simple questions, you are well on your way to determining what kind of study design that you have and the study design that you use. I'm going to pause here to answer any questions, if there are any questions. And yes, thank you for your time. Questions? I can't see
Thank
the
you
chat,
so much.
but I think you can drop
Yes.
your
Okay.
questions in the chat, or you can come off mute and ask your questions. 4
Thank you
simple
so much,
questions
Dr.
to know. Yeah,
Olunkoba. Hello.
you're welcome. I can hear you.
Thank
Go
you
ahead.
so much, sir. There's just this amazing way that you break down these complex topics and make it so digestible. My question is, for our dissertations, we tend to have, what we think is a study question. Then we have maybe 2 or 3 or 4 objectives. And sometimes one objective can appear to be cross-sectional. Then the second can appear to be, maybe it sounds more case control-ish, So
Okay.
how do we decide on which particular, what our topic actually is? I can't really think of any example right now.
I get what you're
But I know
saying.
I've seen some, yes.
I get what you're saying.
So I'd like you
you
to shine some light on that.
Yeah,
Thank
very
you,
good,
sir.
very, very good question. You see, and that's that kind of research a lot of times is I don't want to say it's due to a poor design. It's not due to a poor design. It's due to the fact that in some within, and I alluded to this a little earlier, within some particular study designs, you can be a little flexible. Remember when I was talking about qualitative study design, and some people, they actually went out to do a qualitative study, but the tools in which they are using has quantitative questions. It has, like, imagine that I wanted to go and find out, I wanted to do something about health facilities in Abuja, in Amak, right? And then I got to the facility, and what I'm trying to do is to do an interview with the heads of the facilities. But when I get there, I have one small questionnaire that I want to ask them again too. How many forceps do you have in the facility? Do you have a baby unit? Do you have this? Do you have that? And I'm going to ask those same questions to all those other people I'm going to do interview for. I'm doing an interview, but at the same time, I have a questionnaire there that I'm also asking some. So what you are just combining multiple methods. So when you are combining multiple methods, the first thing is, aside from the study design, the data collection must be very clear. The data collection methods. Remember I said study design will now tell you how you collect your data, right? So if you say your study design is this, then the way you collect your data must also tally with the study design. Now, in most of this research, there's something that is called the main outcome variable. The main outcome variable. Please listen very carefully here, because this is where this is where everything just starts to make sense. The main outcome variable. When you are doing your sample size determination, we're very particular about the main outcome variable, because in all the sample size calculation formulas I use, the most dynamic thing there is your main outcome variable. And that's what you'll be looking for in literature. Any other thing, you're not looking for any other thing in literature most of the times. What you're looking for in literature is that proportion or the level or the mean or the standard deviation of your main outcome variable. That's what you're looking for. So, but enough of times, even though you have your main outcome variable, just like you said, you have 2, 3, 4 other objectives that you just added to it. But the main thing that I'm doing, sir, the main thing is this one. But I just added some other things because of the flexibility that my study design allows me to do, because I'm flexible to be able to do this. Now, here's the catch. Imagine that you said you wanted to determine the prevalence of, and I've done a lot of things like this. I want to determine the prevalence of, you can see some of my publications. I want to determine the prevalence of neonatal sepsis. And then at the same time, that's my first objective. The second objective is I want to see if there's an association between neonatal sepsis and UTI in pregnancy. Okay? And let's just peg those two objectives. Association between, I want to determine the prevalence of neonatal sepsis, and then I want to see if there's an association between neonatal sepsis or I want to see factors associated with neonatal sepsis, of which one of them is UTI in pregnancy. Okay. So these are two stuffs. The first one is prevalence. I only need a cross-sectional study design to do that. That's what a cross-sectional study design is, prevalence. Okay. The next question, which is very common among everybody in the college that is doing this, most of the times you want to do factors, because that's the only way in which you can show some bivariate and multivariate analysis. You want to see factors that are associated with this. Now, those factors that are associated with this, you can find out association with cross-sectional study design. You can also find out association with a cohort study design. You can also find out association with a case control study design. Okay, so if that's the case, which your first objective is a cross-sectional study design, that's the only way in which you can do it, a cross-sectional study design. But your second objective is malleable. You can do any of the three. And what you intended to do is to do a case control study design for the second study, when you go to when you are reporting, if the instruction there, ideally the instruction is to say that you have your study, what you put very clearly is that you have 2 study designs. The first study design is a cross-sectional study, and this helps me to get the prevalence. The second study design is a case control study, and this will help me to specifically identify the association between urinary tract infection and UTI. Now, if the college says by force you must make sure it is one study design, you have only 2 options. First option is to make sure that the study design that you are writing is the one for your main out. If your main work is the case control, which is stronger. Now remember that there's a hierarchy, right? The least is case report. The best is the randomized control trials. If you have one objective that is a cross-sectional study and the other objective is a randomized control trials, which one gives you better evidence? In both of them, which one gives you better evidence?
Randomized control trial.
If you are supposed to drop one of them, if you now you have 2, you are going to report. I'm telling you that the ideal thing is to report 2 study designs, right? But if they say you must report only one, which one do you think is correct for you to report?
The randomized control
The one
trial.
that gives you the highest level of evidence. So you have only 2 options. First option is to, which is the most radical, is to drop, or let me say you have 3 options. And the best option is the first one. Report the 2 study designs that you used. Everybody knows that for you to be able to do this objective is this study design, for you to do is this study design. If they say no, then you have 2 options. This first option is to drop the least one, right? And then report only one. Or the other option is to drop the best one and use only one. And I'm sure you will not drop a randomized trial, or you not drop a case control study to report a cohort study. You will not drop a case control study to report a cross-sectional study. So I hope this is clear. Now I want to point back to the because I've delved a little into sample size determination. If you have 4 objectives, please listen very well. If you have 4 objectives, each objective has a different variable they're looking at. One of the objectives is the main variable. The other ones are some other variables you're interested in finding. Now, I hope you know that even though the sample size determination for you will need to, the most important thing for the sample size determination is for you to determine the sample size using the primary outcome variable, which is your main variable. But even if you do that, it's not enough. It's not enough. What you need to also do is you use all those variables. You have 4 variables that you are finding out. You check literature and look for the prevalence or whatever in all of those 4 variables. You calculate the sample size for all those 4 different variables. The second one is the one that's your main variable, but you calculate the sample size for all the 4. When you calculate the sample size for this first variable, you need only 40 participants. When you calculated the one for this second objective, second variable, you needed 500 participants. You calculate the one for this, you needed only 100 participants. And you calculated the one for this, you need 50 participants. Which sample size are you going to report?
The one that has the highest.
The one that has the highest. So you see, it's always there's a trade-off. The one that has the highest is not the one that is not your main outcome variable. But that is what you are reporting, because you can never ever scientifically find out all the other variables when you are using a sample size that is less than the minimum sample size that you've computed for that variable. If you have more, no problem, it increases the power of your study, and you have to justify that in the college. But if you have less, it can never be justified. You are supposed to use 500, but because of one of the other objectives allows you to do only 50, and then you say use 50. There's no justification for that. They'll just send your book back. You don't have any justification for that. So you always have to strike a balance between all your objectives, and we know 1 or 2 of them are the main ones, and then the other ones are sub. But the ideal thing for you to do, coming back to your question, Khadija, is for you to report the 2 study designs. And like I said again, this is one deficiency that most people have. Most people that do mixed method studies are using 2 study designs. One of the study designs is a qualitative study design, and the other one is a quantitative. Most of the times, they only mention that of the quantitative, giving the quantitative one more credence than the qualitative. Meanwhile, they said they did a mixed method, and a mixed method data collection process. Mixed method is not the design, but it's a data collection process. But that means that you did qualitative and quantitative. You have to mention the study design that you use for the qualitative, and then you mention also the study design that you use for the quantitative. So it's allowed for you to mention more than one study design. Just be clear about what you are saying. I hope this helps.
Yes, I really does. Thank you so much,
Awesome.
sir.
Awesome. Awesome. Jafar, Prince Jafar was raising up his hands. I've been looking for Prince Jafar for a long time, man.
Good evening, sir. Apologies, sir.
Prince Jafar, where did you go now? Haba.
Apologies, sir.
Now so live be.
No, not at all, sir. We had conferences that we were preparing for.
Okay.
Like,
Okay. I hope it turned out well.
Sir, we're almost there, sir. We have not yet completed it, sir.
Awesome.
The preparation was intense. Thank you so much, sir. Sir, I just wanted to ask my question as regards the added cross-sectional study in terms of the comparative cross-sectional study.
Yep.
So you made mention of the fact that these objectives, we should look at in calculating our sample size, we should correlate these are objectives with our study design.
Yep.
In the sense that depending on the outcomes, whether qualitative or quantitative, is going to direct how we get our sample size. I just want to ask, for a cross-sectional, comparative cross-sectional study, why calculating the sample size, sir?
Yeah.
I don't know. Is there any particular formula or is there any particular? But I know for different, each of the cross-sectional typically has some formula for both quantitative and qualitative variables.
Yeah.
For case control and also cohort, but there seems not to be any for a comparative cross-sectional study, sir. I've never seen. Yes,
sir. You've not checked. There's for a comparative cross-sectional study if your primary outcome variable is numeric, and there's for if your primary outcome variable is categorical.
Sorry, sir.
Can you hear me?
Sorry. Yes, sir. Sorry, sir.
Okay.
I had a network glitch.
Okay. So there is for every study design, there's a particular formula for calculating it, whether your primary outcome variable is a qualitative variable or your primary outcome variable is a quantitative variable. Now, the difference there is very simple. There's no, when you are doing a comparative cross-sectional study, remember I told you the questions that you have to ask is a must, right? That must, M.U.S.T, right? And
Yes,
you're
sir.
looking at the number of groups. So you can do a comparative cross-sectional study where you have 2 groups or more groups. But imagine most of the times it's 2 groups you have, right? So you have 2 groups, and those 2 groups, what you are trying to do, remember the idea there, the question. Let's go back to the research question, because you asked a very pertinent question. Remember, the study design is going to help you answer the research question. Your research question in a comparative cross-sectional study must be that, is there a difference in maybe, let's say, the prevalence between this group and the other group?
Yes,
remember,
sir.
right? Because it's 2 groups.
Yes, sir.
Now,
yes, sir.
once you are talking of more than 1 group, 2 groups, there's one thing that adds to that formula that makes the formula just different. I'll say 2 things, but the main thing is one thing. In all the formulas, there's something that is constant. There is Z alpha. That's the standard normal deviate at your particular level of confidence. It's Z alpha, right? So what you have Z alpha. So what you do, that Z alpha is constant for everything. But when you are adding another group, what you want to do, remember the research question is saying, is there a difference? So you are trying to see, you are trying to do a study that allows you to find a difference if it exists. What allows you to find a difference if a difference exists is the power of the study. That's where Z beta comes in. So if you want to know whether this formula is for 1 group or 2 groups, just be looking at the formula. If you see Z beta is for 2 groups. So you will see a formula that says Z alpha plus Z beta squared. Once you start to see Z beta, 2 groups, you will never see any study sample size formula that is measuring 2 groups without Z beta, because Z beta is the power of the study. So this formula that you're talking about, you're asking, is the same formula for comparative studies, is the same formula for experimental studies. The exactly same formula. Z alpha. So I said there are 2 things. The first thing is the Z beta. The second
Yes, sir.
thing now is the fact that because of you have two groups, you can't be talking about, imagine that you are trying to do prevalence. So you want to see if there's a difference between the prevalence in group A and group B. You want to see if there's a difference in prevalence in hypertension, level of hypertension in residents in National Hospital and residents in ABU. If you are calculating the formula, you must have two prevalences there too. You have P1 and P2. Whether it's a cross-sectional study or an experimental study, or you understand. So that's the thing. When you see that formula, it's the same formula for experimental studies that has two groups. You see Z alpha plus Z beta squared into P. You have, that's if the outcome variable is a categorical variable. P, capital P, into 1 minus P squared over P1 minus P2 squared. That's the formula for calculating the minimum sample size for a cross-sectional comparative study if your primary outcome variable is a categorical variable. If your primary outcome variable will allow you to do prevalence. But if your primary outcome variable will allow you to do is a numeric variable, then you are going to be using that same formula, but this time instead of P1 minus P2, you have standard deviation. And this standard deviation in the formula is standard deviation squared. So you have Z alpha plus Z beta squared times standard deviation squared all over D squared. And that D squared is a difference in the standard deviation in the mean values for the two groups. So the formula is there. I have a book. They shouldn't catch me. I have a book. It's coming out soon. Hopefully, it's on calculation sample size. It's a 200-page book, but it's not for jokers. I don't think residents can. It's for people that really want to do research. Residents just want to do their dissertation and run away and do never touch research again. So I'm writing it clearly there. This is not for residents. If you're a resident, don't buy and don't read the book. In fact, part of the books will be free, but if you are a resident, maybe you have to pay 20K for the book. It's going to be printed in China, so it's going to be expensive. All right. Jafar, I hope this answers your question.
Thank you, sir. Thank you so much, sir. Yes, sir.
All right.
Thank you,
You're
sir.
welcome. All
Thank
right.
you, sir.
Jafar is
Thank you.
preempting you.
Okay.
Yeah, supposed
No worries.
I say he's preempting our presentations.
All
Inshallah,
right,
the next presentation you take should be about calculation of sample size.
sample size. Okay. Oh, let's see how it
Yes,
goes.
sir. You will digest it for us. You make it digestible. Thank
It's
you
simple.
so
It's
much.
actually
Sir.
very simple. Okay, I see another question. I think it's very similar.
Yes, sir.
Someone is saying, is there a study design known as cross-sectional analytical comparative study? This is funny, right? A cross-sectional study, you have what is called an analytical study. And the word analytical there is just trying to tell you that there are two groups, right? So if you're looking at the hierarchy, and this is why I said a lot of people get confused, because if you're looking at the hierarchy of study designs, quantitative study designs, the first thing that comes to your mind, remember I said manipulation, right? So it is observational on one side and experimental on the other side. I don't really like going into this because a lot of people get confused there, and that's the authors of this article are a little confused when it comes to there because they are making some tautologies and there. So once you say it's cross-sectional comparative, you're already insinuating that it's analytical. So because these people, what they're trying to do now is they're trying to follow the entire genealogy down from the beginning. You know, from the beginning, it splits into two, observational and experimental. So what these people have said is just like saying you are doing an experimental non-randomized control trials, or you're doing an experimental randomized analytical control trials, like adding all the things in that genealogy, in that tree down, right? That's what these people have done by saying a cross-sectional analytical comparative study. So some authors can take that, but if you say they are just still saying is a cross-sectional comparative study. Now, remember when I was presenting, I said cross-sectional studies are of two types. And that's part of what we just discussed with Jaffa. You have the classical cross-sectional studies. It's classical. It has only one group. Don't come and say anything about that cross-sectional. It has one group. Now, you have also a comparative cross-sectional study that has two or more groups. Okay. one that has 2 or more groups, because you'll be doing an analysis and you're trying to see how those 2 groups are different, exposure and outcome in the 2 groups, how they are different. That's analytical. Now, some people also get a little confused when they go to do a normal cross-sectional study. It's not a cross-sectional comparative study, but they are doing a cross-sectional study. And what they are doing there, they are splitting the study participants into 2, and then seeing if there's a difference between those 2 groups within that. So imagine that. Let me just give an example. Within this, the people on the call now, we have maybe a couple of people on the call, and then we want to see prevalence of hypertension. We're going to check everybody's blood pressure level and see that maybe out of just an example, God forbid nobody has hypertension, but just for example, maybe out of 20 people on the call, we just have 5 people that have, or let's say 10 people that have hypertension. Okay, you've done a cross-sectional study. You got exposure and outcome at the same time, no problem. But now this person wants to now go and split the group into 2 and say, among the 10 people that have hypertension, how many are females, how many are males? Is there a difference between the level of hypertension between males and females? You see now, we had one group. Your research is one group. But within it now, you now split it into 2 groups and then trying to do some kind of 2-group comparison. So some people erroneously call that an analytical study. It's not. The analytical study there for a case control, for a cross-sectional study, is when it is comparative. For a simple cross-sectional study, even if you divide it into 1 million groups and you do all those analysis, it's not analytical, it's still descriptive. It's still just a descriptive study. Difference of opinion amongst scholars here, but I think for me, that's how it is. I hope this helps. Okay, Hafsatu is saying she didn't get the first formula you mentioned while answering the question on comparative study. Okay, so when you are doing a comparative study, the first and maybe I'll send that to Khadija, but it is Z alpha, Z subscript alpha, Z alpha. Let me see. If you want me to write it down, so it is so minimum sample size. Sorry, trying to. Let's see. Okay, so minimum sample size is n equals to, you have Z alpha plus Z beta on their subscripts, and this is squared. Then you have P into 1 minus P, and this P is pooled prevalence, okay, all over P1 minus P2 squared. And I said it's the same formula. It's the same formula that you have for experimental studies, or when you're doing a quasi-experimental study. It's just there's some difference in the interpretation of this bottom here. But you see, this Z alpha is the standard normal deviate at your own particular level of confidence. This Z beta is what I was making noise about. That's the power of the study. This is what gives you the chance to know whether the study can really, how can the study really tell you the difference between P1 and P2 from among the people that you are studying, right? So this is the power of study, and typically people use 80%, typically, but you can go as high as 90%, 99%. Z alpha, people use 95% if it's a normal study, and people go as high as 99.9%. Okay, so this P is pool prevalence, and then this is 1 minus P, so this is complementary probability for P, and then this P1 is the prevalence for one group, and P2 is the prevalence in another group, and this is when your primary outcome variable is a categorical variable, and that's only when you can have prevalences. So I'm going to send this out. I don't think it's something we can explain very well here. I'm going to send this out for Khadija, and so I think you get it a little more there. So Jafar is asking a very interesting question in the chat. You see, a couple of formulas have their names, but these names are not necessarily conventional, because there's a lot of confusion with regards to these names. And for me, and I've advised my other colleagues to, even in the college, for me, you shouldn't be particular about the names, because you see that in my book. The names are controversial. Somebody will say Fisher's formula. Somebody will say, what's that very popular one that they use in surgery? Oh, thing just skipped my head. Somebody will call it the same formula. Oh, they're calling it so many different names. The standard way that is done internationally is to say the kind of formula that it is. This is a formula for cross-sectional studies when the primary outcome variable is a categorical variable. This is a long name, but that's the correct way to say it, because it removes all doubts from people's mind. Not going to say one is Fisher, one is this thing, one is, if I become angry now, I'll make my own low cover formula. Because I don't know why people are so particular about one name or no name. Hey, Cochrane. So Jafar is saying Cochrane. There's one name, it just skipped my mind. Those surgery guys, they like that formula. They like that name. Is it the same formula? They just, people say Fishers, people say, because if you look at the history of some of these things, there's some that these formulas were derived from other formulas. And some of those formulas are attributed to some people, and some of them have not, and there's some kind of conflict. So let's don't be so this Fisher's formula that what all of us are making noise about. If you look at the origin of this formula, it dates back to maths, maths, physics. I beg. So don't worry yourself about name, Jafar. Please don't worry yourself about name. Write it clearly there. Let everybody be clear about what you are saying. You are using the formula, and then you have to put a reference. For all these formulas, you must put a reference, right? So, but the clearest way to say it is, I'm using the formula for cross-sectional study when the primary outcome variable is a numeric variable or is a quantitative variable. I'm using the formula for case control studies when the primary outcome variable is this or this. In some instances, there's no confusion about the name, but clearly when you say it this way, it's incontrovertible. There's no controversy at all about that. I hope this answers your questions. Any other questions? Khadija, over to you. Is Khadija
Thank
still on
you
the call?
very, very much, Dr. Olonkova. It's always a delight having you put us through these complex concepts and making it so easy for us to comprehend. So I'll call on our chief, Dr. Eunice Onu, to give the vote of thanks.
Hello, everyone. On behalf of the editor-in-chief, Dr. Khadija, members of the editorial committee, and the ESCOs of the NHA, I sincerely thank Dr. Olorukoba for improving our ignorance in the topic of study design this evening. His prowess and mastery of the topic has, as you can see, has been evidenced by the fact that he's been talking and trying to explain it and breaking it down for us to really understand it and not just cram it. So we're really grateful for your time and the effort you put in always whenever we call on you, so that we'll be better in this in our research work. We thank you, sir. We are grateful. I also thank our audience who has stayed with us from the beginning to now. In fact, at a point we were 46. So we thank all of you that have been patient from the beginning till now. Thank you. And we hope that when next we are holding a seminar like this, you join us. I wish all of us success in our endeavors, and I wish us to pray we'll have a good night rest this evening. Thank you all once again.
All right. Thank you, everyone. Have a wonderful rest of the evening.
So, if I may ask,
Thank you, sir.
when are we having such, please?
Thank you very much, sir.